Well, welcome to Progenesis Academy webinar, session number 15. Today, we will be discussing unexplained infertility and treatment options. During this webinar, we will have a number of patients that will be asking directly our panel of experts, fertility specialists. And after that, we can go into a full discussion. It is my pleasure to welcome Dr. Westphal, and she is the Chief Medical Officer at Kindbody. Dr. Rodriguez, he is the Medical Director at Texas IVF. Dr. Slater, she is the Medical Director of Idaho Center for Reproductive Medicine. And Dr. Kwas, he is a fertility specialist at Reproductive Partners, also Assistant Professor at UCSD, University of California, San Diego. Thank you so much for joining the discussion.
Thank you for having us.
Well, I'm gonna start first with the same question I have been asking the last few webinars regarding COVID-19 pandemic, how your practice is adjusting to COVID-19 and what are the current challenges? And I will just start from left to right. I will start with you, Dr. Westphal, and then going from left to right.
Well, obviously, this has changed how we are going to practice medicine for quite a while. In the early days, so San Francisco was one of the first places to shut down in the country. And I'm the Chief Medical Officer and oversee 3 clinics. So one's in New York, one in San Francisco, and one in Southern California in Los Angeles. So the impact was a little bit different depending on the public health mandates in each of the areas. But we all, shut down when no one really knew what was going to happen, and then switched everything to telehealth. I think like most other people, and then went back, starting to see patients with the most worrisome patients, the ones, who were older, had diminished ovarian reserve, or our cancer patients, and then implemented all the recommendations that the CDC and our local health departments have required. And so 2 of our clinics are required to do COVID testing within 3 days. So we have implemented that for those patients, and then have the social distancing, are trying to limit who comes to the clinic. So space everyone out, do very thorough cleaning, ask everyone when they come in about symptoms and exposure, and do a temperature check. So far we haven't had any patients who we've had to cancel treatment because of COVID.
Thank you so much. Dr. Rodriguez?
Well, I think that's amazing that you haven't had any patients. I'm here right outside of Dallas, and we're one of the last of the Mohegans as far as a hospital-based program. And we've gone ahead and obviously started all the testing and so on. And actually, to get to my office, you have to go through the hospital entrance, and of course they do the same thing. They the temperature, ask the questions, and mask. Everyone has to be masked. They come to the waiting room, we call, so we do the social distancing. So really, it's a very inefficient way, but it's a safe way, and we only bring, essentially there's 1 or 2 patients. We just have the cycle going. We do a lot of COVID testing, and we shut down also kind of the ASRM recommendations and so on back when, we've been protected for a long time. But then, we've had to cancel patients right before transfer because they tested negative when they started the preparation, and positive right before they went in for hospitalization. Same thing with stimulation for IVF. We started stimulation with a negative test, ended up with a positive, and gosh, and we're doing the PCR, the molecular testing. We have the ID now, which is obviously, it's not as accurate when it comes to false negative, but sometimes we have to rely on that right before. But yeah, we're seeing a big effect. We have had patients delay. We have this COVID Zoom again. I think we've seen the digitalization of the United States in 2 months, as opposed to several years in the last part of because of COVID. But anyway, yeah, things have changed a lot. They've changed a lot. But again, what we try to do is like all of you try to do, is have the patient feel comfortable and safe going through the process. And not so much, I feel better about the stimulations and the egg retrievals than I do about creating pregnancies at this point, because we still are trying to gather that information as to the effect of COVID on early pregnancies, which we have no clue what that's doing at this point. Anyway, that's what we're doing here.
Very good. Dr. Quast?
Yeah, I can echo what the previous speakers have said. I think things have obviously changed in a major way. So I just noticed that you can see here in the picture, this heart is all the dots. Like every day when I walk into our clinic building, they do temperature screening. And so every day I collected one of those little dots, and they've now made a heart. So obviously we do temperature screening on patients when they enter the clinic. We pretty much exclusively do telehealth, except of course for the ultrasounds. I think from a human perspective, the one big thing that has changed is that obviously, just like in society, there's much less touching, and there's no more handshakes. And so it's sometimes a bit tragic when, for example, let's say somebody has an unexpected miscarriage or something like that, where usually you would maybe put a hand on the shoulder or give the patient a hug or something like that. Unfortunately, of course, nowadays with distancing, we're a much less sort of touchy-feely, and also husbands are no longer allowed in the room unless it's an exceptional situation. So I think that it has definitely changed things in a major way. But there have also been some good things, like, for example, the telehealth has its own advantages. I think people like to do consults out of the comfort of their home. The other thing is that, the way that we check in patients, we really do it in a way that the waiting room is always empty, and that patients don't have to interact with each other in the waiting room. So I think that's been working out well. Also, husbands have been bringing in their samples from home, and some husbands actually prefer that rather than producing their specimens here. So some good changes, some bad changes, and we'll see how it evolves. But our volume is almost back to normal. So I think in terms of the actual interruption of services, it wasn't too bad.
Very good. Thank you so much. Dr. Slater?
I have to echo what everyone has said as far as it's just been an inefficient process, but things are still rolling ahead. We're social distancing, we're disinfecting more, we're counseling more. We have another consent. There's always one more consent.
Right.
But overall, the patients are happy to be back. And so we were only closed for 3 weeks, and the pregnancy rates, we're fully in operation, and pregnancy rates are very good. And counseling, the data that we're counseling the patients with is reassuring also.
Very good. Well, we're going to move to the topic of infertility, and we have some patients that are going to be asking live. Riley, can you please take the first call?
Yes, of course. So our first patient, her name is Chelsea. Chelsea, are you here?
So when we get the question, we're going to have two physicians answer the same questions, and then we take the next patient, and this way we take more questions overall.
So we're just waiting for Chelsea to respond.
So while we are connecting with her,
Yep.
I'm going to ask a quick questions, and then while you are preparing maybe her mic. So
looks like she's muted.
Yeah. So the topic is that we are trying to discuss today is unexplained infertility. And obviously when you have a patient, you have to take a lot of measurements. You have to take their AMH, you have to look at, history of miscarriages and all these things. How common is unexplained infertility? How do you define it first, and how common it is? And I can take the first, anyone who would like to answer this.
I can answer it.
Very good.
So I'm actually so happy that I got invited to this, because whenever I see patients with this diagnosis, I always start by saying that when you Google unexplained infertility, I'm proud to say that number 2 or number 3 of the search result on Google is my article. And that's in part because I Google it pretty much every day to keep it up there. And that's this article that I wrote actually as a resident. So it's like 12 years old. And it wasn't exactly published in the New England Journal of Medicine, but it is actually, it became the most cited article, because I think everybody who tries to write something about unexplained infertility just references that. But anyway, it's about 20 to 30% of couples that we see. It feels more, because it feels like I have this discussion almost on a daily basis. And of course, it's a diagnosis of exclusion after ruling out the most common other infertility factors, such as ovarian reserve decreases, anatomic factors, male factor, or ovulatory problems.
Very good. Let's take another answer, Dr. Westphal.
I agree. I mean, overall, depending on the patient population, it probably is about 20 to 30% that come in and we have no explanation. And, for a lot of patients, I think that's the most frustrating situation to be in, that, we just don't know why they're not getting pregnant. So, their fallopian tubes are open and it looks like they're ovulating, and the sperm look okay. And, so there may be other tests that in the future we will have to explain some of these patients. But I think it is one of the more frustrating diagnoses for patients, because when we do our treatments, we aren't able to target a specific problem. So we're just trying to do something for some factor that we haven't been able to pinpoint.
Very good. Thank you so much. Any other opinion? Very good. So let's take the next patient. Riley, can you please help us get a question?
So we have this patient. Her name is Delarem. Would you please be able to tell us your questions? Hello?
Maybe you can troubleshoot the mic with them before we get them in, Riley.
Yep.
Okay. So should we troubleshoot, or should I go with the next question?
Please go with the next question.
Okay, perfect. Okay, so we talked about we tried the live questions, but what we're gonna do is we're gonna take the other questions that are already asked. So Miriam, maybe you can take the questions that you have received.
Yeah, sure. I'll start with the first question. So the first patient asks what causes her AMH level to be so low. She said she's 38 years old, but was told that she has the AMH levels of a 44-year-old, that she may be going into early menopause. So she's asking what can she do to prevent that from happening?
And that question will go to Dr. Slater.
Sure. So the AMH level is a marker for ovarian reserve. It's not egg, quality, it's egg quantity. And usually the egg quantity will have a relationship with age, inverse relationship. So the older you are, the less, egg quantity you have. And if you have a low egg reserve, then that's something typically that you're born with. Some people are born with a gene for, high cholesterol, low cholesterol, or low egg reserve. So it's not anything typically that you've done, unless you've had chemotherapy or radiation on your ovaries, which, is a small percentage of the population. But typically it's more of a genetic issue. And there's not, a pill that you can take or exercise that you can do to improve that. But, you know, generally just stay healthy. Everything in moderation is the main thing. And even if you have a low egg reserve, pregnancy can still happen. It's just, you know, you're not going to get as many numbers out of the fertility, like in vitro fertilization.
Fantastic. Miriam, can you give us the second question?
Yes. Second question is from Lee. She's 39 years old and she attempted 4 IVF cycles. Each cycle resulted in 3 to 5 eggs, and then at the end of the 4 cycles, she ended up with 4 abnormal embryos. She said that she was subject to high dose stimulation with the 4th IVF cycle. And then, so she was wondering if stimulation can affect the euploidy of an embryo, and if so, what would you recommend in her situation?
Dr. Rodriguez?
Well, at 39, unfortunately, I think these studies have been done, and I think there's good medical evidence to support that it's not the stimulation that affects the euploidy of the embryo. And unfortunately, it's usually an egg or an oocyte issue because of age. You know, it's a hard thing to realize, but I guess menopause is not premature if it happens after 40. But I think this is representative of the age-related increase in abnormal eggs in aneuploidy, which results from that. You know, after 4 cycles, it's a matter of, and again, y'all get different things, but after 4 cycles, I think, you know, we have to start thinking what other alternatives are there. You can't change the genetic of the egg, unfortunately. And this is a harsh reality. I had 2 of these Zooms today, similar patients, and, you know, they're at that verge where, would you consider egg donation? Most don't want to hear that, but, you know, when's enough, and when have we really given the best shot that we can? I think it's different for everyone, but this is not a function of stimulation. I think Paulson did that study at USC. I'm not quite sure, but.
Very good. Just a reminder, this patient had 4 cycles. Each one led to 3 to 5 eggs. So that's a total of almost 20 eggs. Only 4 embryos were resulted. Dr. Westphal, what's your opinion? Does stimulation impact aneuploidy or euploidy?
Aneuploidy is usually related to age. So probably the stimulation is not what led to the aneuploidy. And we know by the time women get to 40, the majority of the eggs are going to be chromosomally abnormal. There's no way to reverse the aging process. We know that, you know, every month it's a different cohort of eggs, and, you know, so it still is possible that there could still be, you know, a good quality embryo. But I think, you know, after 4 cycles with no normal embryos, it's probably time to think about considering other options.
Fantastic. Any other opinion about stimulation? No? Okay, so Miriam, can you please take the next question?
Yes. Next question is, are there any studies or evidence around chromosomally abnormal Bay3 embryos when transferred that self-correct and results in a healthy baby? Also, what are your thoughts on mosaic embryos? Do you recommend transferring them?
Dr. Kwasi?
Thank you for giving me this question, because I was able to do a debate on mosaic embryos at PCRS, and of course the conference got canceled. So I think just to add to the general sort of framework of the topic we're talking about, and I will get to the mosaic and the day 3 in just a second, but I agree with the previous responses that decreases in ovarian reserve in some ways are the hardest cause of infertility to treat. So when I see patients at the initial consult, I always show them this little overview that has, I don't know if you can see this, but it has male factor, ovulatory factor, anatomic factors, and ovarian reserve as the main causes of infertility. And I always tell them that ovulatory factor, anatomic factors, and also male factor are very, relatively easy to treat. So all the ones except ovarian reserve are often very treatable. But ovarian reserve, when the eggs get old, our problem is that as of now, we cannot create new oocytes. So like a woman is born, unlike men who create or produce new sperm every day, women don't make new eggs. So there is an age-related increase in aneuploidy, so an age-related increase in the amount of abnormal embryos. And so regarding the genetic testing of the embryos, I think that the first thing about the day 3 is easy to answer. As a field, we've gone away from testing embryos on day 3. So I think that the standard of care of PGT, whether it's PGTA or PGTM, is to test embryos on day 5, which means to biopsy the developing placenta, the trophectoderm of the embryo. And so mosaicism is a complex result. It's basically a lab result that is in between normal and abnormal, in between a euploid embryo and an aneuploid embryo. And so the recommendation is, if possible, to make another attempt to create euploid embryos if all you have is a mosaic. But for various reasons, some couples may be interested in transferring a mosaic embryo, and it has been shown that they can result in live births. But I think as a minimum requirement, I would want the couple to meet with a genetic counselor, because this is such a complex topic. And then usually I spend more time than I have now to summarize this topic and to talk about the pros and cons, because it is very complex. And I sometimes joke that our patients almost need like a PhD in reproductive sciences to understand all this. So it's like really an additional burden in terms of the times of counseling. So the bottom line is, I think rather than trying to transfer a mosaic embryo, I would try to generate more euploid embryos. If that's not possible, under certain circumstances, a mosaic embryo can be transferred.
Thank you so much. Any other opinion before we move to the next question?
I agree with Alex that, we prefer to transfer an embryo that tests normal. And sometimes getting all this information makes decisions much more complicated. Years ago, people were afraid to transfer anything that wasn't considered completely normal or euploid. And then as people have done more studies and people have transferred some of these mosaics, we know that they can result in a completely normal pregnancy. So in those situations, if someone is going to transfer an embryo that we can't say is going to result in a normal child, and even if we transfer normal embryos, we can't say, that it is completely normal chromosomally. But I think with counseling, if those are the only embryos that someone has available, it is reasonable in some situations to transfer those mosaics. And there have been a number of normal children now reported from mosaic embryos.
Very good. Thank you so much. Let's take a question from a patient. Riley, if you can connect the next patient, hopefully this time will work.
Yeah, so we have an anonymous patient this time. Would you like to ask your questions right now?
Yes, can y'all hear me okay?
Very good.
Mm-hmm.
All right, how's everyone doing?
Excellent.
Good. So I am, just to kind of give you a little bit of background about me, I'm 29. We started doing IVF when I was 27, so about 2 years ago. And we have gone through a few different, we've done 1 round of IVF and then 4 rounds of frozen transfers. We didn't get the embryos tested at first because they were graded very highly. Most of them were graded very highly. So we went through 6 that were highly graded, and none of them stuck. I just did another retrieval at the beginning of this month, actually, and we did get these tested. So we sent off 8 to get tested. Only 1 came back that was a mosaic embryo. So the rest of them were normal, very highly graded. And so I'm in the pool of unexplained infertility, and I don't know why. My doctor doesn't know why. But I guess my question for you all, is there something more or something different that I should be doing? And then also, should I look into going to a different fertility specialist clinic?
Maybe Dr. Slater first.
Sure. So no, I commend you for going through all those cycles, and just the fact that you have lots of normal embryos is a wonderful thing. It should happen. Now that you've had failed transfers, we don't know if that was because the embryos weren't genetically meant to be, you know, or if there was another issue. The
Right.
only other test to do is something, there's an endometrial receptivity assay, which is really just trying to look at the timing of implantation to make sure that window doesn't have to be personalized. So that would be the only other tool if you said, geez, you know, I've done everything that technology can offer for the genetics of the embryo. And again, the PGT is looking, does it have the right set of chromosomes? We're not walking every gene, but that's everything you can do, you've been doing. So the only other assessment would be the endometrial receptivity assay. It's almost like doing a mock frozen embryo transfer. And from the time you start progesterone to when they would take the biopsy, a piece of tissue, just to see, does this, are there protein, you know, signature protein expression for implantation at 120 hours after progesterone start, which would be kind of a standard timing for embryo and transfer. And it may be that the assay comes back and says yes, and then you feel reassured, peace of mind, you've done everything you can. Or the assay may come back and say, no, let's personalize this window of implantation to 144 hours after progesterone start. So that's one other tool that you can do, you know, because you've been doing all the other tools.
Yeah, I did. I appreciate you sharing that with me. We actually did do an ERA test for the 3rd transfer, and it came back that I needed 24 additional hours of progesterone. So that was really awesome to hear that. And then we transferred. Now, granted, that might have just not been a genetically good embryo that we transferred, but it still didn't work. And so I am doing another ERA test, so I'm actually getting that mock cycle set up. So hopefully we'll have more answers with these genetically tested embryos moving forward.
Thank you so much. Any other opinion in the panel?
Well, if I may say that, the ERA should not change for you. It's your genetic makeup. I don't quite understand why you would repeat an ERA. I mean, join in if y'all disagree. That's what the good thing is about the ERA. It's your personal window of implantation. And some people may say it hasn't been valid. I use it personally, and I think it's helped a lot of our patients. And because there is no standardization of how many hours. Actually, it's based on the fact that progesterone is the switch that turns on these endometrial receptivity genes. And like Dr. Slater said, it's very useful. But again, unless I'm wrong, somebody help me, but I don't see the reason for repeating an ERA if you've got that data already.
Yeah, I would agree with that. If there's been no new surgeries or anything other yeah.
No.
What other testing have you had? What type of evaluation of your uterus?
I feel like I've done a lot, honestly. So I appreciate both of you sharing that, Dr. Rodriguez. And I think the reason why my doctor recommended to do the ERA again is because my protocol is different. And so doing exactly what the protocol would be now with the ERA results. But I have done the Receptiva to see if there was any underlying endometriosis that came back as negative. They did like a full panel testing on me. I did have my tubes removed, so I had a hydrosalpinx back in 2017 before I even started IVF. And so I did go that route to have both of my tubes removed to make it the chances of success with IVF higher. But we've done so many different testing each time. They've tested to see if I have fibroids or polyps or anything, and everything comes back crystal clear. In fact, every time I do a frozen transfer or an IVF, everything is like almost crystal clear, perfect. This is exactly what they want to see. Everything, my lining looks great. My body responds really well. The only thing is, for whatever reason, my embryos won't stick.
One other thing, if I may add, and this is kind of on horizon, is the actual bacteria makeup, the microbiome of the uterus and chronic endometritis. I know it's not spelled out exactly yet, but in cases like this, we have failed implantation. We got to kind of think outside the box. And interestingly enough, we have had some cases of, and again, this is anecdotal. I'm not a researcher, but I depend on you guys in the academic centers to tell me what to do. But, you know, the chronic endometritis is an interesting thing. And it takes a special stain, and I know, but it has helped in certain cases. And in your situation where you failed so many transfers, I don't know if your doctors considered that or not. The chronic endometritis, and some of it it's pretty bugaboo to try and get rid of. I mean, it's a long course of antibiotics and so on with Flagyl and other ones. But anyway, I know studies are going on with this, but it has been helpful in a certain population of my patients. And then the other thing is, God forbid, to consider in HLA tissue. I mean, you know, how many failed implantations? Is this a combination? As heck, I've been to San Diego many times, so a lot of your courses, and where, you know, I know this group of Spaniards that have done these things, that there's certain, God forbid, that there's certain genetic combinations where, you know, even if you pick this embryo and put it in a gestational carrier, which I've done, and that particular patient has failed implantation. So, you know, yeah, there's a lot of things that we still don't understand, but I think chronic endometritis, it's a simple test. It's a biopsy. It's a special stain, a CD. It's an immunostain CD, I don't know, 138 or whatever that pathology can do. I don't know if y'all found that helpful or not, but I have in certain situations.
Very good.
Yeah, I've had patients where that's the Emma and the Alice, I think Dr. Rodriguez is talking about. It's available in Europe and it hasn't been FDA approved here. I've done studies with it, but I have had patients where I've just treated empirically and said, let's just, you know, take 1 or 2 weeks of antibiotics and then 10 days of probiotics, you know, just to improve the microbiome.
Fantastic.
Okay.
Any other opinion in the panel before we move to the next question?
Well, maybe one short last comment about this. So it is very unusual at age 29 to have so many unsuccessful attempts. But when you look at it in a different way, you've done 2 retrievals. And of course, that's not unusual to do 2 retrievals. It's just the number of transfers that has been unsuccessful. That's a little sort of unusual. But to a certain extent, persistence is often the key, especially when you're young and the ovarian reserve is not yet really the issue. And it's surprising how many patients there are who are successful on a sort of high number of attempts. Like, so I would recommend not giving up anytime soon. Obviously, you have all these tested embryos now. And then the only other thing that I would say is a gray area is adenomyosis. You know, and that's a very sort of diffuse diagnosis. But if there's any suspicion of adenomyosis, we've had some success in treating patients with Lupron, which is a GnRH agonist, for 3 months before a transfer, similar to when you have endometriosis. But that would be something else to consider in the future, potentially.
Okay, thank you.
Thank you so much. Riley, can you take the next patient?
Yeah, of course. Thank you so much for asking a question. The next patient we have is Chelsea. Hi, Chelsea. Hello? Hi, Chelsea.
So maybe the mic is, while you're trying with her, you could probably ping the next patient, and we're gonna have Miriam read for us the next question before I go into one comment. Miriam?
Sure. Since we were in the topic of PGT, so the next question is, although most practitioners prefer frozen embryo transfers, are there any situations where fresh embryo transfers are preferred?
Very good. And maybe we'll start in the same order, so this way we could take all the answers. I'll start with you, Dr. Slater, and then maybe Dr. Westphal after that.
Yeah, I think there's definitely still a role for fresh embryo transfers, and you have to evaluate everyone individually during their stimulation. But if the hormone levels, the progesterone level before the trigger shot, is less than 2, stimulation hasn't gone long, I feel very comfortable doing a frozen embryo transfer, especially in ladies less than 35. We'll look at our own internal data, and I think most doctors will look at their internal data. And with our data at our clinic, the fresh and frozen, less than 35 is the same. Now, above 38, there is a 10% difference. It's lower in the fresh than frozen, and keeping all things considered the same, non-PGT. So I think there is still a role. And there have been some recent studies that have come out that probably the other doctors are aware of with the Megaset trial, where the fresh and frozen data is the same. And very interestingly, the fresh transfer, they biopsied the embryos, but they didn't know the results. And so they transferred the embryo. And in the frozen transfers, they actually knew that they were PGT normal, and the fresh and frozen had the same pregnancy rate. So I don't think it's for everyone, but there's certainly still a role. And I think you have to evaluate everything and make that decision with, yourself and your doctor.
Yeah, so I agree. If you're not going to do PGT and you're not going to test the embryos, and if you're not overstimulated and your progesterone levels stay low, I think it's perfectly reasonable to do a fresh transfer. And especially young patient who's not going to do PGT, who has low progesterone levels, I would do a fresh transfer.
Any other opinion in the panel?
And it will probably come up where, well, some people say, I don't get a fresh transfer, but you can have a positive spin on that also, that your ovaries were such good responders, that you were responding well, probably getting higher eggs, that was the reason that you didn't get the fresh, is that there's just the higher hormone levels that preclude you from doing a fresh. So, you can look at it either way. There could be a positive on both sides.
Thank you so much. We had a question on the thickness of the lining. Miriam, do you have that question? Would you like to ask?
Yes. So the patient is 35 years old. She started treatment at the age of 32, but she's now 35. Her first transfer was canceled because her lining was too thin. It was 4.5 to 5 millimeters. And then during her second treatment, she had a lining of 6 millimeters and ended up miscarrying at 10 to 11 weeks. So the patient was taking Viagra and estradiol 3 times a day, but her lining did not seem to improve. So she's asking, what are her treatment options to improve her lining?
Very good. Dr. Rodriguez and Dr. Kwas, if you would like to comment on this, what are the best options?
Well, what was the reason for her miscarriage? And with these genetically tested embryo?
I don't think she knows, or at least she did not comment.
You asked a question. Well, okay. As far as the lining is concerned, obviously we all want to see that trilaminar pattern on ultrasound. We'd like to see it over, 7 millimeters, but we can't attain that with, actually, we all have patients probably we're doing right now. Viagra's just not really been a big aid to me, although I still throw it in there every once in a while, but it really hasn't been. But an interesting thing is, and Dr. Slater, when she referred to the ERA has been helpful in that we've had some patients that, we can't get over 6.2 millimeters. But, we do an ERA and they're receptive, and we do transfers and we're successful. So, I feel more comfortable with the thicker lining, but I think the ERA kind of helps a little bit and trumps some of those thinner linings. I mean, it offers some reassurance. But all different techniques, to try and get a lining thicker. Some people use Lupron, that's fallen by the wayside more and more now as far as preparation for frozen embryo transfers. You use estrace, you use the patches. Some people have even had to resort to a minimal type of a stimulation in order to get the lining thicker for the actual FE or frozen embryo transfer. But again, it sounds like she got implantation. She got to a point of 11 weeks of pregnancy. We don't really know if that was a genetically normal embryo. Now, what was the reason for the miscarriage? But the good news is she got implantation. So I think it's very helpful.
Dr. Quas?
Yeah, I would agree with that. I think sometimes we're so obsessed with the numbers, the thickness in that scenario. There's actually been some studies that suggest that maybe the pattern of the endometrium is actually more important than the thickness. And in this particular case, I would agree that we're not certain that the thickness of the lining caused the miscarriage. So this is something that I feel like I spent my days talking about cause and effect when things happen. And I often tell the story from medical school. My first day of my cardiac rotation, I admitted a patient who had a heart attack, and he had gotten prescription glasses the day before, and he was convinced that the prescription glasses caused his heart attack. And so in our field, it's filled with putting together cause and association. And so yes, her lining was 6 millimeters. And yes, she did have a miscarriage, which are common, but one didn't necessarily cause the other. So I would agree that she has proven that she can have implantation. She has proven that she can have the formation of a gestational sac and the early pregnancy. So I would recommend to persist and try again. We usually, as our sort of standard protocol for frozen embryo transfers, use a programmed protocol with patches and then progesterone injections, but we sometimes also try the so-called COH FET, which is controlled ovarian hyperstimulation, to achieve a thicker lining. And we also do more and more natural cycles. So it's interesting, different patients respond to different protocols differently. So it's worth trying different things.
Very good, thank you so much. Any other question, Dr. Westphal?
I agree that sometimes patients do better on different types of protocols. I think in this situation, you can't say that the miscarriage was related to the lining being, a little bit on the thinner side. But in patients who, we have a difficult time getting a thick lining, sometimes we'll try stimulation with tamoxifen. And sometimes I'll, try pentoxifylline. So sometimes, just trying a different type of stimulation, adding some of these other things, you can get a thicker lining.
Very good. Miriam, can you please give us the next question?
Hello. Oh, I believe this is our next patient with a live question.
Hi. Hi, this is Chelsea. I apologize, everyone. Apparently I'm technology challenged today. So I actually have kind of a similar question to some of the other individuals who have been asking questions. So I'm 32 years old. I've been diagnosed with unexplained infertility. We did 2 rounds of IUI. And then this last July, we did our first round of IVF, and we ended up with 6 PGS tested embryos. We've now done 3 transfers. The first transfer, we were not successful. We did not get pregnant. The second transfer, we decided to try an extra day of progesterone. So we did, I believe it was 6 days of progesterone, and I did get pregnant, but miscarried at 7 weeks, 1 day. And then we just went through another transfer, again with the 6 days of progesterone. And unfortunately, at 7 weeks, 1 day, I had an ectopic pregnancy. And the embryo, or I'm not sure what stage it is when it's 7 weeks, but it still had a heartbeat. So it was very different from the miscarriage that had happened previously. So I'm just kind of curious. I know you've mentioned the ERA test, which we've now been recommended by a different doctor to do. And I'm just kind of curious if there's other things, if there's, like I've never been shown to have a blood clotting issue, but if that's anything the doctors would recommend. Just kind of curious on what your thoughts are on my kind of unique situation.
I will start. Whoever wanted to take this question, that would be fine.
Sure. So I mean, I can answer because it sounds like you've had different issues happening, which is unfortunate. But there's not one thing wrong, so there's nothing that seems that can stop you in the future. The ectopic pregnancy, you know, if it was from an embryo, was it from insemination or IVF embryo transfer?
It was an IVF transfer, yes.
Yeah. And that could just be from cramping during the procedure, which is very, very rare, less than 2%. So the chance of that happening again is very, very low. And then the failed implantation with the first transfer, I mean, 65% of the time you do a transfer with a PGT normal embryo, you get a baby. It's not 100%. So there's nothing really wrong with you. I would say the ERA for more information, but I think Dr. Kwasa said this before, just perseverance pays off, and you're lucky that you've got lots of good embryos. But I don't think, from everything I've heard, there's nothing really wrong. It's just need perseverance, need to keep trying.
Thank you.
Mm-hmm.
Thank you so much. Any other opinion in the panel?
Well, I think she was questioning maybe a recurrent pregnancy loss type workup. Did I hear you right? Somebody had recommended you get some studies done as far as?
Yeah, so we're actually looking to switch doctors because my previous doctor wasn't necessarily suggesting that we run any additional tests. So I asked to do a recurrent pregnancy loss test, and there was nothing that really showed up on there other than like a little bit low with my folic acid. But other than that, nothing was shown from the recurrent pregnancy loss test.
Very good. Any other inputs before we go into the poll? We're going to release the poll from the patient questions. Okay. Very good. So William, I think you are muted.
I'm here.
Very good. Can you read the results from the poll?
Yes. So the results from the poll, the first question that was asked, are you currently seeking any fertility treatment? 76% of the respondents said yes. The second question that we asked was, how comfortable do you feel about starting treatment during the COVID-19 pandemic? 52% said somewhat comfortable, and 32% said very comfortable. The third question was, have you ever been diagnosed with unexplained infertility? And 52% of respondents said no, and 48 said yes. And then for the fourth question we asked, it was a multiple choice question. What are your expectations with your ongoing or future treatment? And the most popular response was better communication and support from my doctors and clinics, followed by more information on my treatment to help me understand my success rate.
Thank you so much. This is the second poll that we get with very similar results, where most patients emphasize the communication aspects between them and the physicians. I think that is very important. The almost 50% rate of patients said that they don't have any explained fertility, and so it looks like it's even more common than what you guys were describing earlier. We have another. I'm gonna take your guys' opinion on the poll, maybe one or two, and then we will move to the next patient. We have one more patient live that is going to ask a question. Any feedback on this poll? And I'll start with anyone who wanted to take the. Well,
I think patient communication is very important. And you know, it's kind of disappointing to me that they feel like, I don't know, it feels like maybe we're not doing as good a job as we want to as far as communication with patients. And that's a point that I'm taking well, and that hopefully we'll try and improve on that.
Very good.
And I guess the poll also shows, you know, people are, you know, mixed about how they feel about proceeding with fertility treatments. Some people are comfortable and some are not, in the middle of this pandemic. And, you know, I think we're all learning every day is new information. So it's understandable that some people may be a little bit worried about going forward at this time.
Thank you so much.
I do have a comment, just because I agree. I mean, communication is key, and just to communicate with the unexplained infertility, I think the numbers are sometimes daunting. You know, you come to your doctor's office, you've been trying for a year, and you don't realize how, you know, hard it is to get pregnant. You always think it's easy. But there's been a lot of data that if you've been trying for over a year, that, you know, your pregnancy rate just doing nothing at home is 3 to 4% per month, which is very, you know, low. And if we do Clomid and insemination, it's 10% per month. And so just to have those clear communication expectations. So, you know, if you do 3 cycles of Clomid insemination and you don't get pregnant, don't give up. I mean, statistically, there's still options for you. There's in vitro. So I think just to know, you know, what the statistics are and really objectively evaluate that when you're trying to make your best plan for your treatment plan. And, you know, in vitro fertilization is much higher statistics, more expensive. And there's not a right or wrong, whichever path people take, but just, I think, to have good communication and to have good clear expectations.
Very good.
Yep. If I can add one more thought to that, I think, you know, we're talking about unexplained infertility, and the fact that it's unexplained, I mean, of course, you could view it positively. Great, there's nothing wrong, but you could also view it as an extremely frustrating thing because there's nothing wrong, but we're not getting pregnant. And so I think what the difficulty, the challenge in communication is, and as this also the last patient example shows, is that more tests are not necessarily beneficial always. So I think our field as a whole has shifted from doing test after test after test in this area of unexplained infertility. For example, endometrial dating was one thing, laparoscopy, postcoital test. There were so many tests that we've done away with because they didn't work. And we're more pragmatic, and explaining that to patients, I think, is the challenge. And that's also the key to the understanding that we are a little bit more empiric about this diagnosis, and we don't necessarily do test after test after test, but we try to achieve the goal that we and the patients want, which is a baby. And one last thing I want to say, like, I noticed that my parents from Germany have logged on to this webinar, so I just want to say hi to them very quickly.
Very good. I think we have one more patient, Riley.
Yes, of course. So this patient, her name is Libra. Hi there.
I'm here.
Hi, you
Can
can
you
ask
hear
your
me?
questions now. Yes,
Oh,
we
okay.
can hear you.
Okay.
I think we have a technical issue with the voice.
Oh,
So meanwhile, you're troubleshooting with her. We
okay.
have 2 more questions that are on Miriam's list. Miriam, can you give us one more question?
Sure. Next patient is Galina, and she asked, have you had much success with diminishing ovarian reserve cases?
And I will start. I think the last speaker was, the last participant was Dr. Slater. So maybe we'll start with you this time.
Yes, I mean, with diminished ovarian reserve, like I had said before, it doesn't equate, you know, reserve is quantity, not quality. So it really boils down to getting that one that's meant to be. So you can be successful. And, you know, if you're doing in vitro fertilization, you may not get as much benefit out of that technology. So there may be more risk walking into it, but it still can be successful. Mm-hmm.
Very good. I think this question has been asked before. Would you like to get to the next question, Miriam? I think you have another one there.
Yes. Next question is, how much do thyroid conditions contribute or play a factor in trying to conceive, and what are the recommended ranges for TSH, T3, T4, and vitamin D when trying to conceive? And then how can I increase my FET success rate with hypothyroidism?
Okay. Dr. Westphal?
So the recommendation, if someone has a TSH over 2.5, is to check thyroid antibodies. So if the TSH is under 2.5, patients shouldn't need any treatment. If it's over 2.5 and they have antibodies, usually people will start them on a low dose of thyroid medication to get them under 2.5. But if someone is well controlled with their hypothyroidism, it should not impact their chance of getting pregnant.
Very good. Dr. Kwas?
Yeah, thank you for giving me this question, because I'm on the ASRM task force of updating this document that's called Subclinical Hypothyroidism in Patients with Infertility. So actually, if people are very interested in this, they can go on the ASRM website and access this document. But essentially, it says what Dr. Westphal just said, which is that in asymptomatic patients, if they have a TSH in the normal range and negative antibodies, we don't believe that treatment is of any benefit. If they do have positive antibodies or TSH of over 2.5, then treatment can be considered.
Fantastic. Any other comments? Okay, so when you talk about, unexplained infertility, obviously you look at many places, and it looks like we look a lot at the genetic testing. We look at different way of diagnosis. Where do you think we have not explored as far as finding out or understanding unexplained fertility? Where the potential is? And I'll start with Dr. Slatter, for example, and then I'll move forward.
Geez, there's so many things we can try to discover here. I think endometrial receptivity is always, we've kind of scratched the surface. No pun intended for those, the scratch test, but with looking at the timing from progesterone to implantation. But there's many other factors, I think, even to look into potentially immunological factors. That's one thing. And then I'm not the male fertility specialist, but it'd be interesting to talk to the urologist to see, are there more testing that we can do for male fertility? And, if there's DNA damage on the sperm, most of the data hasn't shown that, but I feel like there's a lot that we don't know. And when someone says it's unexplained, it doesn't really mean it's unexplained. It's unexplained with what we've tested. We haven't found an explanation, but there still could be something out there.
Absolutely, absolutely. Dr. Kwas, any comments? Where do we need to explore more as far as research or just additional, science to understand some of those unexplained fertility issues?
That is the million-dollar question, because, we're trying to explain something that's unexplained. And of course, our field, that's basically what all of our efforts are geared towards. One thing that comes to mind is in the old infertility textbooks, there was a cervical factor that we don't really talk about that much anymore. So I think that one of the reasons why we don't talk about that much anymore is because a simple IUI could potentially overcome that. And so there are certain areas where the pragmatic nature of our approach sort of kind of like obviates the need for further research if it's easily treatable. I think the part that is challenging is when the egg quality diminishes with age. So when it's unexplained infertility / DOR / decreased ovarian reserve, I feel like we have a lot of patients who have unexplained infertility, but their AMH is a bit on the lower side. So I think overcoming the challenge of ovarian aging is going to be the challenge of our field going forward.
Very good. Any other comments?
Well, I think another factor is, this is kind of in line what you do, Dr. Rock, is testing these embryos, okay? I mean, we're also looking at a euploid embryo. In the euploid embryo, they don't necessarily have the same capability of implanting. I mean, there are other factors. I mean, I know we're still looking for those. You're looking at the mitochondrial index, and that doesn't seem to be it quite. But there may be other things that the embryo itself. I mean, I have an IVF nurse coordinator who's been with me over 30 years, and she's always tried to explain the implantation process. It's pretty incredible, you know, as a lunar landing. But now I think it's more like the Mars rover. I mean, it's a lot more complicated than just the lunar landing, and you know, this interaction between the embryo and the endometrial lining. I mean, you know, I've been at this a long time, and it's just fascinating to me that we are beginning just to scratch the surface, as Dr. Slater, punology, said there, which is true. So again, there's the other areas that interaction of the embryo and the endometrium. I mean, we're talking about gene receptivity. I know, again, you talk about a lot of immunologic things are going on there. You talk about the lymphocytes, all these specialized lymphocytes. It took me years to realize that, you know, when we start talking about all these things, these are just different specialized, you know, lymphocytes that have special roles at that site of implantation. And so anyway, that's fascinating to me. I mean, but I think, yeah, that's another area that we really have to focus on. For years, it was like, well, what's most important, the embryo or the uterus, you know?
Yes.
I mean, I lived through those times. I remember those old textbooks, Dr. Kloss, where we tried to painstakingly do, what was it, Vin Sims, a postcoital test, you know? And the number one reason you got an abnormal postcoital test was what? Because we didn't time it right. That was probably the most accurate reason why we got abnormal results. So in a way, that's why that kind of fell along the wayside too, and that they weren't reproducible. But again, the insemination, as you say, bypasses that. But anyway, that's my 2 cents worth. I think that's fascinating to me, is that interaction of the embryo to the endometrium.
Yeah, just to follow up on your points, there have been some studies where they have looked at the gene expression of embryos in the lab after 6 days till 12 days or so. And the pattern of expression is incredibly interesting. So there are genes that are involved in invasion that are needed for the embryo to implant. So those genes, if they're not expressed at the required level, then the implantation may not happen. And there are other genes that are hormone-based. And I think we know very little about what genes are being expressed and facilitates that implantation potential. And I think that's a great direction to explore. Very good. So we have a poll results. I think we have asked a couple of questions, and we're going to take that results. William?
Yes, so the first question was, did this webinar help to solve some of your concerns? And 53% of the respondees said yes. And the second question we asked was, would you like to see more webinars like this in the future? And overwhelming 95% of people said yes.
Very good. Well, that's definitely a good thing. I would like to thank all of you for helping us answering the questions for these patients. Before we wrap up, we are coming to the end of the webinar, but before we wrap up, I would like to give you guys a minute to introduce your practice and talk to us about what you do for patients. And I will start with the same order. Dr. Slater.
Oh, so my name is Dr. Kristen Slater. I'm the medical director at the Idaho Center for Reproductive Medicine, and we're a full service fertility clinic. We do, ovulation induction with Clomid, we do inseminations, we do donor eggs, we do gestational carriers, PGT testing. So just a full service reproductive clinic.
Thank you so much. Dr. Rodriguez.
Oh, and okay. And I'm medical director of it's a private fertility center called Texas IVF. And we're kind of like one of the last of the Mohegans. We're in hospital still based. It's been a good relationship. Not many hospital-based IVF centers remain. I don't know how long this will remain, but currently, I mean, but we are also our full service. You know, one area that I'd love to get more active in is the oncofertility portion, which I think is underserved in our community. But I'm very jealous of you and bigger centers where y'all are able to do this.
Very good. Thank you so much. Dr. Westphal.
Hi, I'm Dr. Westphal. I'm the Chief Medical Officer for Kind Body, which is a national women's healthcare program. And we provide all fertility services. We have a lot of educational events, many virtual educational things, because we want women and anyone seeking fertility treatment to really feel empowered and understand what they're going through.
Thank you so much. Dr. Quas?
Yeah, so I'm Alex Quas. I'm an associate physician at Reproductive Partners San Diego and also associate professor at the University of California, San Diego. And we're basically also a full service infertility clinic, providing all fertility services. The one, I think, nice thing about our clinic is we put on that conference in Coronado once a year, although it was canceled this year because of COVID. And so I think what that conference does is it brings together fertility experts and fertility physicians from, and of course, lab experts and everybody from the fertility field once a year to highlight and evaluate and critically review all aspects of IVF. I think it's a great conference. And I think what it does is it keeps us evidence-based at all times, because every year we review all the evidence about IVF and we practice what we preach at that conference.
Very good. Thank you so much. Well, with these comments, we are coming to the end of the webinar. Thank you so much for your inputs and for your participation. Next week, we will have another webinar on another topic, Wednesday, 3 p.m. Pacific time. So stay tuned, check your email, and I will see you next week. Thank you so much.
Thank you for having us.
Thanks, everybody.
Yeah,
Thank you for having us.
Yeah.
Thank you.
Good luck, guys.
Stay safe.